Okay, so let's just do a little. Actually, y'all have calculators and stuff in your phones, right? More or less.
Yeah.
So we can. I don't have to draw all the stuff out on the board. I'm just going to sort of talk philosophically about how I would solve some of these problems. If you need a calculator, or take notes or whatever. So the first question was about that transfusion. You had 250 mLs to give over an hour and a half. Now, a couple of people came up and said, we're getting these odd answers that, they don't look like what we're used to seeing. You will have drugs that are delivered at those kinds of rates. There are a number of drugs that are delivered over 2 hours, 2.5 hours, or 90 minutes. So, what do you think you have to, if it's over an even increment of hours, it's really pretty easy to figure out your mLs per hour because you don't have any decimal places or anything to mess with. So what do you think you have to do if it's not 1 hour?
250 by 1.5.
You could do it that way. Or you could convert your 1.5 to minutes, which is how many minutes is an hour and a half? So if you divide 90 into 250, what number do you get? Hmm?
250 in the 90. Or
90 into 250.
You get 2.77.
Okay. Now multiply that by 60.
62. Sorry,
166.66. Now, just, Yeah. So, as I mentioned, but it didn't quite sink in for everybody, pumps only do integers. When you're programming a pump, you can't program it to 166.6 or 66 or whatever. You either have to pick 6 or 7. And the truth of the matter is, it's not critical. Because if you program it to 167, if it's really perfectly accurate on the volume in that bag, yeah, you might run short by an ml. It might try to deliver 1 ml more than it really has in the bag. But what most nurses do, at least the ones that don't want to have a miserable day, is you program the pump to deliver like 100 mLs less than what's in the bag. And then it alarms at 100, when it says you're getting down to 100 mLs, the pump will alarm and say, hey, I've delivered everything you said I was supposed to deliver. And you can go back then and double check where you are and fine tune it a little bit and say, okay, yeah, go ahead and give another 90 or 98 or whatever number of mLs you want to give. So you don't have to worry about that. However, when you're doing math in medicine, you never round until the very last step. Why wouldn't you want to round at every step? What is that going to do?
That'll take you way up or way down.
Well, they'll introduce rounding errors, right? So it'll shift it one way or another, and might throw you off. Now, some of you answered with 166, some answered with 167. I'm actually fine with either. Both of those are a valid choice for that pump.
Honestly, I think for all of us, I think we're all capable. It's just we've always had multiple choice. Or even one. So
I'm sorry, you're going to have to think
No, it's
now.
not your fault. I think that's why there were so many questions. It's because everybody was like, well, what's going on? I think that's why we were all bugging you. We were like,
no, I think only like 4 people.
Okay, cool.
I didn't. That was not a lot of questions.
Okay, cool. Because I was seeing all this out there.
You have a question.
I was just, I think this is the only, one of the first tests that we have that isn't multiple choice.
And you have to actually write it down.
Yeah.
The thing is, it's you don't have the,
Yeah, as opposed to the one I put up as a practice quiz last night. I actually, believe me, I really wanted to do that. I thought Moodle had the capability where I could say, here's the right answer and here's the formula.
You did. It does kind of.
Yeah, it's really ugly.
Well, I mean, it's still gives a little.
Yeah, that was the closest I could get to it. And it was really, but even that really was like, I didn't want, that's why the rest of them were multiple choice, just because it would have taken me 3 times as long to put that test together as well, anyway, it really did not lend itself to you figuring out the answer and plugging in how you got it. But anyway, so So okay, yeah, you'll get a couple more of these from me. That's well, I may have to make you think. Oh my goodness, yeah, okay.
So on our exam next week, are we gonna have MedCalc on it?
No.
Yeah.
So that'll be multiple choice.
Okay.
It's a Scantron, yay!
I was gonna ask if it was gonna be multiple choice.
No, it's all gonna be multiple choice. It's a Scantron. You'll survive. So you can fall back to your standard habits, but it will be an NCLEX style test. Now I think I have opened up the review. May not be opened up yet. There was a
transfusion one last night, but so when it
no,
says,
I'm talking about the one there's both transfusion. Well, there's transfusion and infusion review questions that are in the
for next week.
Yeah, did you start looking at those? Okay, so they're open now?
So just to clarify, because I know a lot of people were confused about it, thought that the transfusion little check mark thing was a quiz last night. So when it says review, we are not being graded on it.
You are not being graded. I have not put up anything yet that you are getting graded on.
That's what I mean.
So even though they're quizzes, these are actually all marked as review. So they're there for you to their practice. Now, I do expect you to do them.
Oh, no,
I actually go look to see who's done what. And that's why they do close eventually. But anyway, you had a question. Yeah, was that you the one that emailed me, or somebody else emailed me about that too? So I actually just read through the lecture, and I think that's an artifact from last semester. So I'm not going to add any additional reading in the last moment here. But we can talk about perfusion, and if I talk about it too much, then you might have to answer maybe one or two questions. What is perfusion? Oxygen's involved, but
oxygenation of the tissue through nutrients.
What? It's the blood going through the tissue. So yes, there's oxygen, carbon dioxide, nutrients, and all that other stuff involved, but it's about keeping the tissue full of hopefully fluids that are useful. Getting back to our quiz here, another one that threw people. There was the insulin drip, and the bag came up. It had 100 mLs of and 100 units. So how many units is that per ml?
One unit per whatever.
Per ml, and if you're going to give 8 units per hour, what's going to be the rate?
8 ml per hour.
Yeah, that's pretty easy. But you gotta, you have to look at what the question is asking. I have 100 units, I have 100 mLs, 100 in the 100 is 1. Okay, so now I just need to figure out what my rate is.
When are you grading these bad boys by?
This afternoon.
Nice.
Like from 4 o'clock on, after I give the other group theirs.
Okay. Clarification also. So what's on the exam? Is perfusion not on the exam?
Not really, except unless I talk about it a lot, and then we can sort of... I mean, if I talk about it for like 20 minutes, you might expect a question on it. But in terms of, based on what the reading that I've asked you to do, the reading is going to focus on transfusions and infusions.
Okay, because on here it says it is...
I know what it says.
Okay, cool.
Like I said, last semester was a little bit different. I copied last semester, tried to edit lots and lots of pages. Okay, good.
I was just clarifying.
I know, you're just as compulsive as I am, so it's okay. Okay. So can you mix different insulins together? Depends on which ones they are, yeah. But, yeah. You can mix, a long-acting with short-acting, something that's like a 24-hour steady. You can put those two together. So you need to know your insulins, and actually that's really important in this class.
So was that 9 units, or was that a trick question?
It's 9 units.
I don't know if that was a trick question.
No, it wasn't a trick question. At least it wasn't intended to be. It wasn't the plan.
What was the TPN one? That was the over.
Okay, so let's figure this one out. The TPN. You have a 1 liter bag, right? And the TPN bag has to be changed every night at 6 p.m. So how long do the bags hang? Right. So how do you figure out the rate for 24 hours for 1 liter? So what answer did you get? $42, yeah. Yeah, if we had a 25-hour day, it would come out exactly 25. Or 4, I mean, excuse me, 40. So, I mean, really setting the pumps isn't hard. The challenge that people run into with pumps and dosing, pumps work in mLs per hour. What do your orders all say? Are they ever in mLs per hour? Oh, what are your orders? How are your orders designated? What? Milligrams, micrograms, units? Is that going to drive everybody crazy? Just me, okay. Okay, so where people get messed up with pumps is they confuse the rate of the pump with the dose that's being administered. So that's where you have to pay attention. Is that, if you have a bag that comes up and it has, 1 gram of something in it, and it's ordered that you're to give, 1 gram over an hour, what's the rate? You can't figure it out because I didn't tell you how big the bag is. Okay. So, if that bag has 250 mLs, what's the rate? 250 mLs, you have an hour to administer. What's the rate? 250 an hour. How many grams are they going to get? Fine. That was in the bag. If that same thing comes up and it's in a 100 ml bag, you're going to run it in 100 an hour. They're still just going to get 1 gram of whatever that drug is. So it matters to know how your drug is diluted, so that you can verify that the amount of drug they're getting is in sync with the actual order. Because the pump won't tell you that. Well, actually, the neural ones will, but in theory they will. Or if you're just hanging a bag, And I noticed most of you figured out the one that had a drip factor. Very good. Because we haven't even talked about drip factors yet. 33. Yeah, well, the point is, if you're doing gravity, administration sets have different drip factors. Did it explain there what a drip factor is?
No.
So what do you?
We did it in Farm 1.
You did it in Farm 1. So what's a drip factor? Yeah.
Drops per milliliter.
Thank you. So there are, I've seen at least 3 different drip factors on, quote, standard IV sets. I've seen 10, 15, 20. I saw one that was like weird, 17. And then there's micro drip sets. What's a micro? Have you ever heard of a micro? Yeah, so what's the drip factor on a micro drip? Usually they're about 60. If you were to set up a gravity drip, how do you figure out how many? You actually did a good job. You figured out how many drops per minute. How do you figure out the rate that's going? How do you figure that out when you're actually physically hanging your bag? You want your watch and the drips. Yeah. So if you have something that is, let's say it's 20 drops per ml for your drip factor, and you want to run it at 250 an hour, how many drops per minute? 250 mLs with a drip factor of 20. 83. So do you think you can comfortably count 80 or 90 drops per minute? It's getting up near the upper end. You can probably pull it off. But you know, when you start getting over a drop per second, it's hard to count because you're looking down, you look back, you look, you know, or you're sitting there and trying to count. Also, that's why a digital watch will be a problem for you. Because now you're trying to count pulses and count drops. Can you do that? Will your brain do that? Mine won't. When I was a carpenter, I could only remember one number at a time. I'd go measure something and somebody would ask me about a dimension. And then I'd have to go back and measure again because, what was that? What was the language? Okay. Any other questions on med math for the moment? From what I saw, it looks like most of you probably passed with just a quick glance. But I will do my best to relieve your anxiety and get these graded. Let any of you know that if you need to do the second attempt as soon as possible. Yeah, let's put it this way. I know it sucks, but how about if I just email those that need to retake? So if you don't hear from me, what I'll do is I will send an email to the group saying I've graded everything. If you haven't heard from me, you passed. How does that sound? That way you get you know for sure whether that you passed. If you passed, okay. 10:30. Okay. Well, shall we talk about transfusions a little bit?
Can we take our break from tomorrow?
Yeah. What the heck? Go for it. Y'all want to bring back some food? I'm hungry.
Well,
let's see. I went to bed at 1. I got up at 4. No, that's fine. That was a joke, by the way. 42. Oh, it's not. But don't panic. So, we haven't really talked about pumps. There was just a note at the top that said they only do integers. So, you did the math right. That was the point. Okay? Okay. Tell me your name again.
I'm Morgan.
Morgan, thank you.
You're welcome.
Me too, but I was like that too. I was not.
There we go.
You're gonna hit something.
Have any of you ever received blood?
Yes.
Yeah.
Wow. Did it scare you at the time?
No, not really.
Would it scare you now?
No.
Okay.
I helped prime the line.
You helped prime the line for your own trench?
Oh, no. I haven't given blood.
No, I didn't say give. Received.
Oh, no.
So none of you received blood? No autologous transfusions? So, let's see. Any of you know what a cell saver is? Have you seen that in the hospital yet? Sometimes after surgery, they hook people up to a special pump that, if they're bleeding, collects the blood, and it can be reinfused.
I know when I had my C-section, before I had a scheduled C-section, and before I had my C-section, they took blood from me.
You banked that as an autologous transfusion.
Yeah. So is that the same thing? That they
No,
take
this
it
is like if
before
you've had some major surgery where they expect there to be bleeding. They will actually, they'll hook up a pump that collects that blood, and then it can be reinfused.
Okay, so they collect the blood that you lose?
That you're bleeding, yes.
Oh, okay, so they don't take blood before and then use that. It would be they take whatever you lose.
Well, it just depends.
Yeah.
I mean, it may be both.
Okay.
You know, it depends on the surgery and what the plans were. So, 32,000 units per day in the U.S. alone. That's a lot of blood. What are the two main complications, do you think, that can happen?
Hemolytic reaction.
Okay. Yeah, okay, so bloodborne diseases and transfusion reactions, those are the primary issues. You know, blood is a high alert. This is actually, you know, they really, in the hospital, they try not to give blood because there's problems associated with it. Did you know that blood that is, the oxygen carrying capacity and efficiency of the blood, if it's an old bag, if it's near its expiration date, is significantly less efficient than the blood that is fresh? Makes sense, yeah. But anyway. So, I better put my glasses on. I can't read my notes. I'll tell you, getting old is a challenge. So, you know, HIV and stuff like that, actually, you know, they do screen the blood really, really carefully at this point. But it is still possible. And there, you know, there is the Gann Act, which happened in the late 80s due to Paul Gann, who received HIV from, you know, an HIV-infected transfusion. And they also screened for Hep C. Interestingly enough, when I was somewhere around many of your ages, Hep C was really kind of unknown, unheard of. But there's a number of people in my generation that are suffering from it because they experimented maybe even just once with IV drug use. And they happened to get blood from, you know, I mean, they shared a needle with somebody who was already, Hep C infected. So that's how you get Hep C. It's not a good plan. Did I talk about that sufficiently? Yeah, I think so. So let's talk about Dorothy here. She had a left total knee. How are you guys with acronyms? What are you going to see when you look in the chart? Is it going to say total knee replacement? What are you going to see when you're reading that? I think I heard you. Actually, you're close. It's actually a TKA. Arthroplasty. So, yeah, we don't call it a replacement. So it's a total knee arthroplasty. What's a THA? Right, a total hip arthroplasty. Anyway, there's some other good acronyms out there that have way too many syllables in them. So prior to her, yeah, I think it is 9 grams per deciliter. You were asking me, Karina? No.
Oh, yes.
You were asking about milligrams versus... I need to go double check whether it's grams or milligrams. I inherited this lecture from somebody else, and I occasionally find things that are like off by a factor of 10 or 100. Actually, what's the difference? What's the difference between a gram and a milligram? 1,000. So sometimes they're off by, 3 orders of magnitude, as the engineer would say. So, if you see somebody that has, a hematocrit of 9, a hemoglobin of 9 and a hematocrit of 25, would you be worried about them?
Yes.
Yeah, for most people that's probably a problem. Now, one of the things that's interesting is, in the hospital, you'll find that normal is very different from what you see in your book in terms of, the normal labs or what's acceptable. When I worked in the cardiac search, the CVOR, the cardio. See, this is what happens with 2 hours of sleep. CVICU, cardiovascular ICU. These were the open heart patients. And so if they had these numbers, a 9 and a 25, they would not be a candidate for transfusion. They're not low enough. because they're expected to drop that low or lower. And there's other things that can affect those values. What do you think could make those values actually incorrect? Even, I mean, they're correct in terms of the lab, but that might throw the values off.
What do you mean? Like, why would they have these levels after surgery?
Yeah, what you have a heart patient who, you know, they did a valve replacement or whatever, and you're looking in this, you see this H&H of, you know, 9 and 25, and the doctor says, oh yeah, no problem.
Well, there's blood loss after surgery.
No, they maybe not haven't actually lost that much blood. What else can affect these numbers?
Medication.
Not medication. What were we talking about last week? What was the topic? Infusions? What if you've given them 5 liters of NS? What do you think that does to the numbers in the hematocrit? It's called dilutional. So I'll look at it and say, oh, that's dilutional, don't worry about it. They actually anticipate this because they've gotten so much fluid that those numbers are going to drift down. So they really actually have enough red blood cells, they have enough blood, it's just it's in a much larger volume. See, you didn't know that, did you? Or have you heard the term dilutional before? Anybody heard that in the hospital? No, that's not with an E. This is DILT. Well, not DILT, but anyway, that's diltiazem. DILUTIONAL, dilutional. It's been diluted. Okay. So, but in this case, she's hypotensive and dizzy and weak. So, what are you going to expect? They're probably going to say, hey, you know, she donated a unit. Let's give it to her. So let's talk about blood types. All of you have some type of blood. And do any of you know your blood types? I see a couple of nods. Would the hospital ever give you that type of blood based on what you tell them? No. People, you know, you could be wrong. So what are they going to do in the hospital when you come in? If you need blood, they're going to cross and type. Cross match and type. They're going to type and cross match. So they're going to take, you know, they're going to run the test to say, what type of blood do you have? And we're going to find a suitable match for a transfusion if you need one. So this typing and cross-matching has to do with the antigens that are on the surface of the red blood cells. And there's actually like more than 32 different antigens, but it turns out there's only about 3 that we really care about. There's A, B, AB, and RH. Does that sound right? Did you guys read? Is he making any sense? Yeah. Okay. So what about type O? Is there an antigen there? No, that's why, yeah. So, what happens if you give somebody the wrong blood type?
Reaction. I think they call it agglutination, right?
Yeah, so what's actually going on there?
It like clots up together, and then it goes into the capillaries, I think, and then it stops like blood flow and...
Sure. So what's the process that's causing that agglutination? Yeah.
The antigens stimulate the antibodies.
So what's the 2-word definition of that? I'm thinking in broader terms. You're on the right word there.
What did you say?
You got the right concept.
Immune response.
Immune response, yes, there we go. Okay. So our body says, I don't know whose blood that is, but it's not mine, get rid of it. We're going to attack it just as if it was a bacteria or, you know, some other kind of antigen. What's an antigen? Something is foreign. Yeah, the body says, I don't, it's not part of me. So you have the antigen and antibody reaction, and that's what's going on. And that's what causes the agglutination, because part of that process is antibodies cause things to stick together, and when you stick red blood cells together, that's the basis of forming, thrombus or clots and stuff. And how small do the capillaries get? They're just big enough for one red blood cell. So what happens if you glue 3 of them together? It's gonna, yeah, so what happens to the circulation past that point? Stops. So what happens to the tissue? Starts to die, yeah. Not good. Okay. So much of the population is type O, which actually has no antigens on its surface. Isn't that cool? So what kind of a donor is type O? Universal. See, you guys, you've done your reading. Isn't that wonderful? Who's the universal recipient?
AB.
AB. Why is that? Yeah, because they're not going to react to any of those because everything looks familiar. O looks familiar because it doesn't have any surface antigens. A looks familiar because we're type A, and B looks familiar because we're type B. So there's you wouldn't call it a chameleon, but it basically as far as the immune response is concerned, it's saying, yeah, looks familiar. I know who it is. It's okay. What is the RH factor?
Something about the RH, whether you're negative or positive for that.
Yeah, well, what is it?
It's the D antigen.
Okay. So it's another antigen.
D antigen.
Does everybody have it?
No. So if a mom's negative and a baby's positive, that's bad.
Why is that?
Because the mom that doesn't have access to the D antigen, so it's like foreign to her, so it's going to start.
Oh, it's going to look like a foreign. So what happens with mom if fetal blood is introduced?
The second time she's
Yeah, so it's just like being, she's been sensitized. So with RH, usually it does take a little while to form, and often, usually with the first kid, it's not a problem. So that's why they will, if there's, a RH mismatch, you give mom, what do you give the mom?
Rogam.
It's a couple of slides down, but Rogam, right. And what does Rogam actually do? Anybody know? Yeah, basically masks, it makes it look like there's no RH factor running around in the blood. So mom's immune system is not stimulated to respond to it. Cool. Yeah? Well, you would give it every time that there's a mismatch between the mother and, anytime mom is RH negative and baby is RH positive.
Every RH positive.
Well, if mom's RH positive and baby's RH positive, is there a problem? No, because they match. So it's only when there's a mismatch and mom is negative and baby's positive. If it's the other way around, is it a problem? No, it's not a problem because if mom's positive and baby's not, baby's blood doesn't make mom's immune response react. So it's just that one direction.
So mom negative, baby positive, you give the program every time.
Every time they have a kid that is positive, yeah. Yep. Yeah, it's not like it doesn't see it's not like a vaccine that stimulates your immune system to respond more quickly. In fact, it's the opposite. You could call it sort of like an anti-vaccine. It hides the fact that there is some RH positive blood in the system so that the immune system, in fact, does not respond and doesn't develop the antibodies to that. Kind of an interesting, the body's really pretty cool. So let's talk about, let's go back for a second. So if we gave Dorothy an RH mismatch, it would probably probably be okay. I mean, if you had a type mismatch, that's a much bigger deal, because then you get into the hemolytic reactions. What do you think would be her symptoms if we gave her an incorrect blood type? What are the symptoms of a transfusion reaction?
Fever,
What else?
Pain, whatever the heck.
Where can the pain be?
Lower back pain.
Where else?
Chest.
Yeah.
And the infusion site, there's like burning sensation.
Yeah. Okay, good. I'm so proud of you guys. You're reading. I love it. So we're going to talk about a hemolytic reaction briefly here. So as we talked about, with the antibody antigen, it causes this clumping, or as you mentioned, agglutination. Perfect. It's a good word. And then what happens after that is it breaks down. That's what does the word hemolytic mean, actually? If you break the
Lysing.
Yeah, lyses the red blood cells. Exactly. So who is the one that's most responsible for preventing a hemolytic reaction? The nurses, you guys, the ones hanging the blood. So what's the procedure for blood? So you just grab a bag and hang it? Somebody want to tell me what they... Now, technically, in theory, none of you have actually hung blood, I hope, because there would be a violation of policy in pretty much any hospital I know of. Well, actually, I'm going to go back here. Okay.
So you check name, you check birthday, and you have another licensed personnel there with you.
What else do you check?
Blood type.
You're going to check the blood type.
Expiration.
And,
Expiration.
yeah, check the expiration. There's also a serial number on the bag as well. You check that. Yeah, there's a whole bunch of stuff you check with blood. Yeah.
So we did a transfusion last semester.
So you assisted, right?
Well, I was there.
You were there. Good. You weren't hanging the bag.
No,
Yeah, okay, because that has to be licensed person.
So what they do is they send out an actual nurse has an RN messenger has to go down and pick up. It depends on the hospital.
It depends on the hospital. Policy about who picks up the blood is flexible. Policy about who verifies and administers, not flexible. Has to be licensed. But they can send somebody down to pick up the blood. A student could even go down to pick up the blood, although most hospitals wouldn't allow you to handle it. So, where are we here? So what's the procedure when you hang blood? How often do you check vitals? Before? 15 minutes? Yeah.
Take vitals.
You have to stay in the room for 15 minutes.
I'm going to say that you probably aren't going to find people staying in the room for 15 minutes. Realistically. Okay, so that's the NCLEX hospital? Yes. In the NCLEX hospital, every patient has their picture on the bed with them, and you stay in the room for 15 minutes to observe for a hemolytic reaction. In reality, you're going to hang that back and you're going to pop your head back in within 15 minutes, check for any signs of a reaction, talk to the patient, ask them how they're doing, or look for symptoms if they're not conscious. And then as far as drawing blood for, type and cross match, that's also a very specific procedure where 2 different people have to be involved in that, and again, signatures, initials, time, and if you send a tube down for type and cross match and they're not filled out properly, you start over. Because the blood bank just says, go away. So with a type, you have a type A negative patient, which of those would be okay to give? Are any of them perfect?
No.
No. But it's an emergency. What are you going to give? O negative would be the best choice there. A positive might be okay if you're really desperate, but yeah. Because O is the universal donor. Right. So we already covered this. Isn't that cool? We talked about RH and we got that taken care of and out of the way. So, like we said, with the first child, it's usually not a problem. The first, if mom's negative and the baby's positive, you're never going to have a baby again, it wouldn't be a problem, or it's a problem if you might have another kid. Okay. So that's RhoGAM. So it's given actually in the 28th week and then soon after the baby's born. Why do you think RhoGAM is given during the pregnancy?
Placenta.
I hear words.
Placenta. I'm going to say the baby's inside the mom, living off, the placenta.
So is there any blood exchange between baby and mother? Actually, there is. That's been one of the recent discoveries is like, oh my God, there's a lot of fetal blood floating around the mom's circulatory system. So that's why it's given, because it turns out that there is crossing across the placental barrier. It used to be that they thought it didn't cross. Yeah, go ahead.
I was going to say, I was also reading an article recently about how baby's DNA from blood stays within the mother's body after she's had the baby, and that's part of the motherly baby connection.
Yeah. Part of their genetic legacy.
Yeah.
Okay. Cool. Good stuff. So this is where you type, screen, and cross-match. And it basically, have any of you actually done this like in physiology class or anatomy or anything like that?
Yeah.
Have you, like in your prereqs, I see a couple of nods. Was it cool? Did you end up with, like one that looked really grainy and the other one was okay? Cool. Okay. So what kind of blood is it when you're getting blood that's not your own? There's a term for that.
Transfusion?
Well, no, you're gonna. So it's called allogenic, which means it's not yours. When they draw a clot for a type and cross match, is it good forever?
I think it's 72 hours.
Yeah. So what happens if at 96 hours you realize your patient's anemic and they need to do a transfusion? What are they going to have to do? Yeah, they have to draw another blood sample and send it out for type and screen cross match. Exactly. Do any of you give blood? Cool. I used to until my blood got too polluted with drugs. Well, prescribed. Yeah, I'm on Coumadin, so they don't really want my blood in. I do, although I do sometimes go in for plasmapheresis, because that is still usable. But everything else is.
Do they allow you to give blood even though you're on Coumadin, which is a blood thinner, correct? Doesn't matter?
Yeah, no, they allow me to give blood, although there are times if I'm going in for injections, they're very cautious about it. Can we stop using the word blood thinner?
Oh, sorry.
Please? Just that wasn't directed at you, because it's come out in both sections. I know it's in common use, and if you're talking to your patient, it makes sense. But when you're talking to your colleagues, call the drug what it is. Call it.
Anticoagulant.
It's an anticoagulant or antiplatelet. Depends on the drug, but or call it by the drug name. He's anticoagulated, as opposed to he's on a blood thinner. That just sounds like something you're talking to the 70-year-old. I take this pink pill, and that's my blood thinner. Okay, good. So the conversation is different between professionals than it is between the general public. And I talked about this briefly last week. What's the reason for using some of those other terms?
The layman's term?
No, not using layman terms when you're talking to your colleagues.
Well, it just makes you sound like you know what you're talking about.
Well, that's one thing. It's nice to have people think you actually know what you're talking about. The other aspect of it is it's unambiguous. Blood thinner could be one of about a half a dozen products. So on Coumadin, it's Coumadin. If they're on Plavix, it's Plavix. And they work differently. I mean, they accomplish some similar outcomes. By the way, what's the reversal agent for Coumadin? Somebody's been in an auto accident, they're on Coumadin. What do you give them?
Plasma. Plasma?
No, what's the coagulant?
Yeah, it's not going to really, plasma's not going to really help much. But somebody's going home on Coumadin, what do you talk to them about in terms of diet?
Vitamin K.
There you go. So why? So guess what the reversal agent is? Yeah, it's Coumadin. Excuse me, it's vitamin K. And I use the word vitamin K because when you see the name of the actual drug, it's about that long and I can't say it. Plavix. Is there a reversal agent for Plavix? No. So if somebody's on Plavix and has an injury and they're bleeding internally where you can't apply pressure, what's their problem?
They're gonna die.
They could die. And you can't really do much about it because you can't stop the bleeding. So, you know, from the general public, Plavix is great. I don't have to go in every 6 weeks and have a blood draw. But don't have an accident. You know, don't have a major trauma. So I like actually knowing about the drugs. I'll stay on Coumadin because I know that can be reversed. Yeah, it's a pain. I have to go in every so often and they draw my blood. And then if I'm lucky, I get a technician who doesn't actually go all the way through the vein and into the muscle. That seems to be the new technique. It's like, we're going to make sure and then we're going to draw back. And when I get flash, we're good. I'm like, that hurts.
I have a question.
Yeah. You probably want an answer too.
Type and cross-match. Type is a type of blood, and cross-match, how does that work?
Well, okay, so we know the blood type, but we want to give a transfusion. So what are you going to do?
So you would match.
You're going to match it. So the cross-match just is another word for, we're going to find some, in our blood bank here, we're going to find something that matches the blood that we just typed.
Including the RH.
Including the RH. So they're going to look at they're going to look at the RH, AB, and O. We talked about that. Blood components.
So I have a quick question about
Sure.
anticoagulants.
Mm-hmm.
So like after a heart attack, you have like stents, but like my dad had a heart attack.
Is it a drug-eluting stent?
I don't know what that means.
A drug-eluting stent is a stent that actually has an anticoagulant as part of the stent.
I think
and
these
it
are
basically, so it's a bare metal stent?
Yeah,
Okay.
those are metal. But so he will be on anticoagulants for the rest of his life.
Yeah.
So is that kind of an automatic protocol when you have stents put in metal stents, or maybe
basically anything like that. Why do you
Well,
think?
yeah,
Why do you think
anticoagulant.
stents require an anticoagulant?
Well, so there's no clotting. I mean, you don't want.
Well, yeah, you don't want to form clots in this and stents do clot off, by the way.
Yeah, so that's kind of a permanent thing.
He's going to be on something like that for the rest of his life.
Okay.
And then there's different kinds of anticoagulants you use for people that have like valve replacements versus stents.
Oh, okay. So it does vary whether it's a valve replacement or a stent, or and then what if it was the stent? What was the stent you were saying? Is it has the agent?
A drug-eluting stent actually has like Plavix in it.
So what is that material that's made out of?
It's got
Like a
probably a
flex
silicone
material?
coating or something on it that lets the drug leak out.
Wow.
I think they're good
Does
for
it
like
have to
3
be
months.
replaced? I was going to say.
Well, and that's not replaced, but the point is they are most susceptible to clotting right after the stent is placed. And so the intent is a drug-eluting stent is less likely to clot off than...
And so why would they use that over a metal stent? Like what would be a...
What's the rationale?
Yeah.
Ask the cardiologist.
Okay.
I'm sorry, I don't have a good answer
you're
for that.
fine.
I honestly don't know. I think, with cardiologists, it's personal preference as well as, whatever research they've done, the experience they've had, some of it's anecdotal. It's like, well, every time we do this, they seem to clot off and they have to go right back to the cath lab 3 days later or whatever.
Okay. Interesting. Okay.
Yeah.
Thank
I
you.
have a question about, earlier you mentioned the word allogenic. Is that the same as homologous?
So homologous means, what's the word homo mean?
Like,
Same?
Yeah.
So autologous or homologous means I donated blood and then I'm getting my blood back.
Mm-hmm.
Allogenic means I donated my blood and it went to somebody else. So they're getting an allogenic transfusion because it's not.
Just donor.
It means they aren't the same person.
Okay.
The person getting the blood is not the person who donated the blood.
Okay.
It came from another entity. So yeah, we almost never give whole blood. Partly because it's diluted. There's only really 200 mLs of red blood cells in that 500 mLs of fluid. So what do you think might be one of the issues with giving lots of blood? Fluid overload, exactly. You have a CHF patient. Are they sensitive to fluid administration? So often you will see those patients not only get blood, but they get Lasix at the same time. Let's talk about packed RBCs. I don't remember where it is in here. We're going to talk a little bit about I'll wait till I get to that slide. We're going to talk about what hangs with blood. The most common, blood components given is packed RBCs, packed red blood cells. In essence, they've been centrifuged and they've been concentrated. So there's less fluid and more red blood cells, and that helps improve the oxygen carrying capacity. And you can raise the hematocrit by 3% with every unit, which is kind of cool. So, the larger the catheter, the better when you're giving blood, typically. But if it's the 90-year-old lady, you're probably not going to poke them with an 18-gauge needle if you can avoid it. You can actually give it through 22 gauge, but really the preferred is 18 to 20. Blood can transfuse anywhere between normal transfusion times vary between 1.5 and 4 hours. Why do you think what would be the rationale for a slower transfusion?
Fluid overload.
Yeah, fluid overload would be one. Or maybe you've got, if somebody is, profoundly, they've been bleeding out, you may give it a lot faster than over an hour and a half, but that's pretty much as a pump really has a limit to how fast it can pump. But I have seen in the ICU people using pressure bags to actually force blood straight in. Or I saw one nurse actually standing there squeezing the bag, because this person was bleeding out.
And where are they injecting that into? Is there like
a large vein, hopefully.
Just a large vein.
Might be, it might actually have a central line, a femoral cut down or something like that. Yeah, if it's down here.
There wasn't like a specific spot that they
if somebody has been that badly, traumatized, they're probably going for central lines in the first place. They're going to poke those in really quick because they know they're going to have to give massive amounts of fluids and volume extenders. So instead of blood, sometimes they'll give. Have you heard the term of volume extender? So Hextend. These are products that are not blood products, but they help hold the volume of the vascular system together. So you're going to have a 170 to 260 micron filter, and of course, they need to be ABO compatible.
Now, do you want us, for tests and stuff, do you want us knowing specific details?
You might want to know about filters and typical infusion rates.
Okay.
And maybe even want to know how big it
Size.
yeah.
So why would you give a 260 over? Why would
That'll actually come up from the lab.
Oh, okay.
I mean the pharmacy. It depends. And a lot of that'll be just a sort of the facility itself will have those standards. So what does leukodepleted mean? What does that mean? Yeah. And what about irradiated? Have you had any patients that were receiving irradiated blood? So they are so immune compromised that they can't tolerate really. So they go through and they irradiate the blood to further kill the white cells.
What is it? Further.
This might be somebody that's on chemo, they just, things like that. So, you want to take a quick look here. So you got this Y tubing. Blood tubing is a special kind of tubing. You don't just grab any old, IV set. You actually grab a blood set. And people, I didn't apparently do a good enough job of explaining this last semester, so I'll see if I can do a better job this time. So what do you hang with blood? What else? What's in that other bag?
Normal saline.
Could it be D5?
No.
No, it's never anything other than normal saline. Do you have to give that whole bag? No. That bag is just there to basically to allow you to prime the line and flush the line and perhaps maintain the line while you're getting the next bag. If you're going to hang, if you're going to hang a couple of units. How often is the line changed? Actually, blood sets are changed every 8. They can last for up to 8 hours. You can run 2 units of 4 hours each through the same line, but after 8 hours you have to reset everything up. And so you notice that it's a Y tubing. It actually has both. And so what you do is you clamp off the blood. Well, you clamp off the side that's going to the blood. You're going to spike that bag, and then you're going to spike your normal saline, and you're going to open up, that roller clamp and fill everything up with saline. Actually, you're going to prime the whole thing with saline before you even spike the red blood cell, the bag, the blood. And then once you've primed everything, and you've got a patent connection, then you clamp off the saline and open the blood. You run the blood. When the blood runs out, you clamp that back off and you reopen the saline to flush the line, and then, depending on your orders, you're going to hang the next bag or toss it right. Platelets. So sometimes you will get platelets. Why would you give platelets, do you think? So what job do platelets have? Yeah, so if somebody is having clotting issues, you get platelets. Yeah. That's one of the things you can give. And what are we doing on time? What time? We had a 22?
Yeah. 40?
Okay. So the term for somebody who is depleted in platelets is thrombocytopenia. Any of you have a patient or hear the term HIT in your wanderings in the hospital yet? So since you haven't heard that, I'll tell you what it is. It's heparin-induced thrombocytopenia. So it turns out that heparin, now where do we get heparin from? Pigs, typically. Yeah, porcine. Yeah. So.
Wait, where do we get it from?
We don't make it.
No, I know.
Okay. A lot of comes from pigs. Some horses. There's a lot of other animals that are kind enough to donate heparin. Of course, they kind of die in the process. But so. Can you have an allergic reaction to heparin? Yes. So what happens with people that are on heparin? They can develop, a sensitivity to heparin. And one of the things that happens is it messes with your ability to clot. And so if you have somebody that's like on a heparin drip, or even getting heparin for, on their daily, just, to prevent blood clots, because they're not moving around. You want to watch their platelets. That's part of your, when you're looking at their labs on every day, hey, their platelets are trending down. I should talk to the doctor. Because they may want to change them from heparin to some other anticoagulating agent. What's Lovenox?
I know.
It's a heparin, right. It's low molecular weight. It actually has, because of its lower molecular weight, it has less things on it that trigger the immune system, so it's less likely to cause HIT. I lost a patient to HIT, yes.
I'm not 100% sure, but the patient I take care of, he was scheduled to get Lovenox, but the facility he lives in they weren't allowed to administer it because
It's sub-Q, yeah.
Sub-Q.
So was it a sniff?
No, it's a assisted living community.
Oh, what?
Assisted living.
Oh, assisted living, yeah. You actually need to be able to, whoever's going to give it, either the patient gives it themselves or you have to have a nurse or an LVN. Somebody's licensed.
I mean, their PA I'm a physician to get that.
Yeah, so what's the difference between Lovenox and Coumadin? From that perspective?
Reaction time? Or?
Well, no, it's just that one's a pill and one's an injection. And almost anybody can give pills, and not almost anybody can give an injection. So Lovenox is less likely to cause this sensitivity, yeah.
So how is Lovenox and heparin different?
They've chopped a lot of the molecule off that really is just sort of excess in terms of its functionality. So it's actually known as low molecular weight heparin, if you want to look it up.
So it's pretty much the same, just less.
It's less likely to trigger an immune response.
Okay.
So I did have a patient who ultimately died from heparin-induced thrombocytopenia. He had actually come in. He had gotten some heparin like a couple of weeks earlier, and then he came into the hospital. They were going to do a cardiac cath, and during the cath, they realized that he actually needed to go to surgery for CABG, and so they put him on a heparin drip. And about 6 hours into his stay on the floor, he told the nurse, I'm losing the feeling in my left leg. And they went and checked, and he had a thrombus that actually ran, the entire artery down his leg. And they tried to embolize him, to remove the clot. They were unsuccessful, so they ended up doing a guillotine amputation, mid-thigh. But at that point, because of HIT, he was showering clots. And basically, he suffered multiple strokes. It took him about 6 weeks to die. It was a hard patient to take care of. And it was really tragic because he had a 20-year-old son and an invalid wife, and he was the sole caregiver.
How quickly do they decide to do an amputation like that?
It was in the middle of the procedure. Because he had no circulation to his left leg.
So how
what?
does that work with consent?
Well, he had already consented to the hospital. And basically, when you sign the consent in the hospital for procedures, you're
It covers all of that.
kind of covers a lot of that.
Okay.
Now they're still going to come talk to him and probably reconfirm that, we're going to go in here, but if this is what happens, and we may have to take your leg. He never woke up, so he never really knew what happened to him.
This was all because of
heparin.
the hospital giving him heparin?
Well, he had heparin a couple of weeks earlier, had been sensitized. When he started on a drip, he had this generalized, like a disseminated intravascular coagulopathy, the DIC. And he developed all these little microclots as well as one massive clot.
Is that a severe case? I mean, is there any coming back from that?
Actually, I'm going to give you all a little assignment when you have a brief moment. Look up heparin-induced thrombocytopenia and see the pictures. Yes.
DIC stand for again?
Disseminated intravascular coagulopathy, if I could actually say it. I better hurry up here. We're going to run out of time before we run out of slides. So, fresh frozen plasma. What do we use that for?
For people who have a repair on a fractured hip and are taking warfarin.
So
What did you just say?
That was a question for you.
yeah, it's slide 15 if you read the notes. So it's great it's another reversal agent for Coumadin because it has like all the factors in there for basically all the clotting factors. But it doesn't have any, it's really limited in terms of, you don't have to worry about RH. And there's no antigens, so plasma is not typed to cross-match. Plasma proteins, albumin. We talked about albumin last week, right? So you will get this occasionally. It's usually you see it in patients that are in liver failure and stuff like that. And basically, it's used to help manage pulling fluids out of the interstitial space and back into the vasculature where the kidneys can do their job if they're functional. Last semester. Okay, we're going to move on here. So we talked about this hemolytic reaction. It's, things start breaking down and then you get all these blood products. What happens when you have all this stuff released into the blood, all these broken down red blood cells? Where is it going to end up? Anatomically.
Out. Like gets filtered out.
What filters?
Kidneys.
So all this big chunks, as far as the kidneys are concerned, of debris are accumulating in the kidneys. Do you think the kidneys like that? So that's why they develop low back pain with an acute hemolytic reaction. It's the kidneys actually saying, I don't like this, it hurt. It's damaging the tubules. So they're going to get chills and pain. And why would they get chest pain, maybe? Well, if you're blocking up the blood flow in the kidneys, where else might you be blocking up blood flow? Heart. What about the lungs? So like any capillaries and stuff are going to be at risk for being damaged with these chunks that are floating around in the blood. So what do you do with an acute hemolytic reaction? You disconnect everything except the saline. You're going to keep the saline running. You're going to check their vitals like every 10 minutes, 15 minutes, 5 minutes. Probably going to in the ICU. You have to, of course, call the doctor. You're going to anticipate their meds. Dopamine and diuretics. What does dopamine do? Anybody know? Works on your heart, right? It's a stimulant. Yeah. It's a chronotrope. I think so. What does chronotrope mean? Anybody want to guess?
Color? Chronotrope?
Chrono.
Oh, no.
So a chronotrope is something that affects the heart rate. You'll learn about that later. Okay. What's an inotrope do? Oh boy, there's another one. That's actually not part of this class either. Well, I'll talk about it later during it. So we get febrile reaction. So 1 degree centigrade is considered a febrile increase. And it can happen within a few hours or immediately. And it's due to the antibody antigens. So this is not necessarily a horrible thing. And often you will prophylactically treat your patients with Tylenol and Benadryl. What does the Benadryl do? Or diphenhydramine?
Antihistamine.
It's the antihistamine. So it helps suppress, again, the allergic immune response. And I can't remember what the other thing I said was. It doesn't matter. So, it won't be on the test. I don't know. No, okay. So you can have a mild allergic reaction. That's not unusual. It's not usual, but it's not out of the ordinary. So they get a little, just like sort of like hives or little, blisters. Doesn't that look fun? Now, severe allergic reaction, once again, you got to disconnect, you're going to run the saline frequent vitals. You're going to notify the doctor, and you're going to do orders for antihistamines, epinephrine, and steroids. Okay? Graft versus host disease. We're running out of time here, so I may ask you to go ahead and read about graft versus host, but I'll talk about it real briefly. So if somebody has a really poor immune system, the person with the immune compromised, when they get a blood transfusion, the blood from the donor attacks the blood of the recipient. So that's graft versus host disease in essence. So instead of their immune system mounting a response to the foreign blood, the blood that's being administered sees the transfusion recipient as being the other and attacks it. And we talked briefly about circulatory overload, taking too much fluid. Why do you think you might see hyperkalemia? Why might their potassium increase? Yeah, so if some of the cells have lysed, they release potassium. So like if you're doing a blood draw and you pull too hard, you're going to get a high, the lab will call you up with a critical value for their K being, 5.7. And of course the disease transmission, we talked about Hep C, as well as, HIV and stuff like that. So Dorothy's doing better. She got her blood, hematocrit's up. She's walking around and she's going to go home. So go back and review, all the stuff about giving blood. I'm not going to go through it because it's a page and a half. Yeah?
For your exams, do you need to know the normal values? Do you need to memorize all those?
Or will you give them to us?
It would be good to know the common normal values for things like potassium. Would be a really good one to know. Kind of know the normal range for hematocrit, H per inch and H. Yeah, it's going to make it easier. And I'm not asking you to memorize, but you should develop a sense of like, that's slow, that's not good. We need to be, paying attention to that. That's not a real good answer, I know. Yeah, you want to kind of know your normals. Like I said, in the hospital you find out the normals are abnormal. Or abnormals may be normal. They have a broader range to deal with. Thank you for your time.